Now let us take up the next very important topic, clubbing. Only one issue on clubbing, causes of clubbing. Like a generalized tonic-clonic seizure patient, we used to tell 20 causes of clubbing in the ward rounds. Clubbing, immediately as the professor says, you must tell all 20 causes, then only your seizures will come down. So even entrance demands that. Any cyanotic heart disease like tricuspid atresia, endocarditis, pulmonary AV fistulas can lead to clubbing. Clubbing can be unilateral. If it is Pancoast tumor, unidigital. If it is tophi of gout, or only the upper limbs in case of heroin addicts, etc., etc. There are few exceptions, but generally clubbing is bilateral. Then clubbing, do you find it in squamous cell or small cell carcinoma? What is important about small cell? Small fellow runs fast. So small cell carcinoma will metastasize very fast. By the time they clinically present, already they have a diffuse metastasis and they will have a very short lifespan and they die. Whereas squamous cell carcinoma is having a very insidious and slow clinical progression. So that is the reason, doctor, there is not much of time in small cell carcinoma for the clubbing to develop at all. So it won't be seen in case of the small cell carcinoma. Now in COPD patient, do you see clubbing? We don't see. Any COPD patient develops clubbing, what do you suspect? Probably there is a element of bronchiectasis in that, or probably malignancy. You should always suspect in a COPD patient if he develops clubbing. Then cirrhosis, carcinoma bronchus, bronchiectasis, any of them can lead to the development of the clubbing. And whenever COPD patient has clubbing, think of a concomitant lung cancer. Now once more, what are the causes of cyanosis? What are the 4 T's? You have to remember congenital heart diseases leading to cyanosis, doctor. T for TOF, T for tricuspid atresia, T for truncus arteriosus, and T for tetralogy of Fallot is what you need to fundamentally remember. Now is there any way to differentiate one from the other clinically, cyanotic heart diseases? Look for pulmonary oligemia. In tetralogy of Fallot, will there be pulmonary oligemia or plethora? Oligemia, because there is a pulmonary atresia. In tricuspid atresia, you will have pulmonary oligemia, whereas that is not so in the other cyanotic heart diseases. So pulmonary oligemia, there are not, is one differentiator. Hypertrophy of the heart, I mean cardiac dilatation, is there or not, is another differentiator among the cyanotic heart diseases. So tricuspid atresia, Epstein's anomaly, pulmonary atresia, pulmonary stenosis, complete transposition of great vessels with pulmonic stenosis, or a double outlet left ventricle with pulmonic stenosis, they all lead to cyanosis with a decreased pulmonary blood flow. Now where do you have unilateral clubbing? Pancoast tumor and pulmonary AV fistulas and aortic aneurysm of the arch of aorta, they all lead to a unilateral clubbing is what need to be basically remembered. Similarly, any erythromelalgia, cervical rib, Pancoast tumor, bronchogenic carcinoma, unilateral clubbing. Sarcoidosis, tophaceous gout is unidigital. Now one more question, once more for PGI, clubbing is a favorite question. So interstitial lung disease, you find clubbing, but not in COPD. COPD, if it is there, think of lung cancer. Then any suppurative pneumonia, bronchiectasis, clubbing is a very important feature. Then where do you find a low oxygen content in the arterial blood? In tetralogy of Fallot, there are hypoxic spells. So there is a low oxygen content. Fibrosing alveolitis you find, metamoglobinemia you find, but not in carbon monoxide poisoning. The oxygen content is not really affected. So that is all the story of clubbing. So finally our job is a quick integration of all causes of clubbing. You must know that any pulmonary disease like lung cancer, cystic fibrosis, lipoid pneumonia, any GIT condition like ulcerative colitis, Crohn's, cirrhosis of liver, leiomyoma, achalasia also, Then any malignancies, especially you need to remember Poem syndrome. What is that? P for polyneuropathy, O for organomegaly, E for endocrinopathy, M for monoclonal gammopathy, and S for skin changes. And it is a paraneoplastic syndrome in a plasma cell dyscrasia. In that also clubbing is one of the important feature. Similarly, any endocrine causes like acromegaly, thyroid acropathy, pregnancy can also lead to the development of the clubbing. I like to talk only two important clinical signs, Shamroth sign and Lovibond's angle when it comes to the clubbing. The angle between the proximal nail fold and the nail plate is called the Lovibond angle, is typically less than or equal to 160 degrees. If this angle is more than 180 degrees, then definitively you can say clubbing is there. Lovibond's angle. Then Shamroth sign means if you put the two fingers, a diamond shape will be there. If it is not there, then you call it as the clubbing. So all these things we did in our first clinical posting very interestingly, but later on as consultants we forget all these things probably.